All right, so we'll start now with the second panel. I'd just like to say that before we start this panel, I kind of feel like I'm with Captain Kirk on the spaceship because we're taking folks where man has never been before, okay? So just hang on. The day-to-day challenge of providing health care in jails with difficult patients, rapid cycling of inmates in and out of the jails, lost medical records, all of those kinds of things have resulted in proprietary healthcare industries seeking to develop electronic systems that try to simplify the workload and assure patient safety and track information. Not a small task. Today we'll hear from two chief medical officers of proprietary correctional healthcare companies about their experiences with these systems. Dr. Carl Keldy is with Corizon, and Dr. Raymond Herr is with Correctional Healthcare Companies. Correctional Healthcare Companies started its work with a preferred relationship using a system called Core EMR. Corizon, the largest proprietary correctional healthcare company in the United States, began building its own system known as Catalyst under its predecessor, Prison Health Services. Both of these companies have recently decided to adopt an electronic system to track CPT and ICD-9s, the codes for diagnosis and for billing. We at Cochs believe that this shift is due to health reform and the need to create connectivity between jails and local healthcare systems. Cochs, a couple weeks ago, we sent out some papers to all of you, one of which described some of Dr. Herr and Dr. Keldy's work and experiences, as well as some experiences of Dr. Campolo from Ohio, who unfortunately couldn't be with us today, but we'll have some indication of some comments about his work. But they've in the paper, it talked about developing electronic health data systems. And in this session, what we'd like to do is kind of flush out some of that information, then engage you in some discussions about it. Before we do that, though, I'd like to talk a little bit about the panelists. Dr. Raymond Herr joined Correctional Healthcare Companies in 2007. As the Chief Medical Officer, he has direct clinical oversight for all provider services within CHC and Health Professionals Limited, as well as clinical oversight of utilization management for CHC. Dr. Herr has been involved in correctional healthcare for 2 decades, having served as medical director in many county jails in Colorado and most recently in Jefferson County Detention Facility and Broomfield, Connecticut Jail. In his role as Chief Medical Officer and Senior Vice President at Corizon, Dr. Keldy is responsible for the establishment and oversight of company-wide medical and clinical service policies and procedures, credentialing, infection control, continuous quality improvement, and utilization management for healthcare service delivery to more than 200,000 offenders. Prior to joining the company in 2000, he practiced emergency medicine for almost 20 years and has extensive clinical and administrative experience. And of course, you all are familiar with the esteemed Rosenberg. So, for Dr. Herr and Dr. Keldy, as jails, are jail special environments where so much so that the HIT systems require different information from that in the community. And if you would you tell us about your experiences with regard to HIT in jails and some of the challenges and opportunities you see going forward? Either of you, take your pitch.
Yeah, I don't mind starting. We began with the EHR through Core EMR, and it was a system that worked fairly well for us. We had it at several of our larger jails, and it was a system that helped us deliver care to inmates, and it was not a system that we used to connect with our corporate office. And as time went on, we realized to better serve our clients that we needed a system that would allow us to do the process, and we developed Vision, and Vision allows us to have sites, and pretty much all our sites are connected to Vision as far as the process. They can send us information, requests for referrals, as well as requests for medications, and that is done pretty seamlessly, and helped us, at least as a company, better serve our clients. We two clients. One is the counties that we're contracted with, and the prisons that we're contracted with, but also we consider the inmates our clients as well. So to better serve our clients, both as good patient care, we also wanted the system which Vision gives us to allow us to pretty seamlessly deal with referrals as they come in. It's almost on a real-time basis that we've got requests coming in. They come into the office, they immediately come into the department, and we can turn them around typically with the urgent request, turn around within 24 hours, and medications go, if they're part of our regular formulary, they go directly to our pharmacy electronically, and if they're non-preferred, they come into our corporate office, our department. They can get reviewed again on a real-time basis. So within an hour or two, they're turned around, approved, and then sent over to our pharmacy. So Vision has been helpful to we think give good patient care from the standpoint of having sort of real-time referral review as well as medication review.
Okay. Dr. Kelly?
Thank you. I've been behind bars probably at 200 facilities around the country. My background in emergency medicine really was jail medicine, because that was my first experience with correctional medicine, is when the police officer would bring somebody in handcuffed and beat up and want to know how quickly he can get out of my emergency room. And the real critical point there, they wanted to know whether I was going to admit them to the hospital or not, because they weren't going to arrest them if I was going to admit them to the hospital, so they wouldn't have to pay for them.
Right.
One of the adages in jail medicine is when you've seen one jail, you've seen one jail, and it is hard to standardize care, to reduce variability, to keep patients out of harm's way with paper records that get modified based on heuristic medicine and based on the disease of the day. And we really, our vision was that health information technology applications would reduce variability, would help prompt risk stratification, because what I want to know, who are the sick patients? Who's going to get into trouble? Who is potentially suicidal? Who potentially has active tuberculosis? And that's where I see information technology really assisting in jail specifically.
Okay, could you talk a little bit about some of the challenges that you encountered and what you think might be some anticipated challenges going forward?
How long we got?
Okay, all right.
No. One of the biggest challenges is, I talked about standardization, but we have very fine policies in place, procedures in place, and then the rubber meets the road, and you've got to try to work with what you've got. Many of these jails they were set up as jails, not as places to provide care and screen for care, and you have the ubiquitous workarounds. Yep, I know that's what the policy says, but to make it work, and in order for us to move people out of the sally port where you got 30 people clamoring, we got to do it this way. And one of our biggest challenges is putting information technology, and Homer said it very well, it really puts a bright light on processes. and on policies and procedures and the workaround and the behavior drift that exists in the most challenging healthcare environment I think there is in this country. I thought emergency medicine was hard. Jail medicine is hard on steroids.
Okay, Dr. Herr?
Yeah, I think, the challenges, at least as I try to think about corrections and I try to think about IT, dollars are, the counties that we contract with are all pinched for dollars. So, the smaller jails, the thought of bringing in computer systems for, an electronic medical record is really so far down the road for them. They have other sort of issues as far as where they're putting their dollars. So dollars are probably, at least within the county jail system, probably one of the challenges to bringing in a system. The health communication within a jail is difficult because as an inmate comes in, they get their care from emergency departments primarily. They really don't have primary care doctors.
Right.
And so, number one, they're coming in and they're saying, yeah, I was seen last week. Well, where were you seen? And they can't quite remember because they've been to so many emergency rooms. So what we do when they get into booking is we begin immediately identifying nearby hospitals and saying, hey, do you have any records on this particular inmate? And the same with pharmacies. They say, oh yeah, I get a lot of medicines, and well, where do you get them? Well, I'm not sure. I think I go to Walgreens, and I think I get these from the grocery store or pharmacy. So the difficulty is, number one, their ability to tell you where they get their medications and where they get their care, and then they have aliases. There's you're trying to get information about medications under different names. So there's certainly challenges with that particular group because they don't get their care from the family doc primarily. It's emergency rooms, and it's different emergency rooms. They come from out of state, so it's a challenge as they come into a facility to get the right information.
Okay, so Dr. Kelly, you mentioned the workarounds. Could you talk about some of the potential impacts of those workarounds as we go forward?
Workarounds exist whether you're on paper or an electronic medical record. The electronic medical record doesn't make you ask the questions a certain way and doesn't solve everything. The typical workaround is you have somebody that presents and they reportedly have diabetes. Well, the glucometer got broken on the last shift, so now I'm not going to enter a blood sugar record because I would have to get the glucometer from another place within the jail, and so you put an NA or something. In an electronic medical record, you can actually have a forcing function that requires you to enter that a number before you move to the next question. The electronic medical record also helps you in that if you ask certain seminal questions, it prompts you to take an action. You can no longer write down 3 suicide risk factors on a piece of paper and just kind of go, well, yeah, I guess I remember that's somebody that should be put on watch. With the electronic medical record, it can actually tabulate that and give you a score, and at the end of the record, print out a report to security that this is somebody that needs to go on suicide watch. So that's a couple of examples that an EHR can help with some of the workarounds that happen in this environment, in this workflow-centric process.
Okay. So Steve, can you give us some feedback about Dr. Campolo's story in Ohio?
Sure. I guess it goes back to sort of Hugh's question before. So Dr. Campolo is a family doc in a small town in Ohio who was an early adopter of an EMR, and he got the county to buy the same EMR that he had in his office and put it in the jail with the idea that he could take connectivity back and forth because he was seeing the same guys. Well, the problem is that EMR systems migrate and upgrade, and there's generally a fee for the migration and upgrade. So he kept paying for the migration and upgrade within his practice, but the county wasn't willing to pay for the migration and upgrade in the jail. So what happened is what started off as a totally connected system, small jail, Hugh, going back to your question, relatively inexpensive to do, another license, for what he had going on in his practice soon became this. And that's where we stand today. And I think that that speaks to part of the challenges in general. In your paper, there's an article that was done by the National Association of Counties that sort of speaks to this question. You know, the health care is the tenant, and the jail and the county are the landlords. And so the landlord gets to decide what level of capital improvement that they're making in their premises. And in that case, they decided to not upgrade, which sort of broke the connectivity, which I think speaks to some of the questions on the challenges within the small rural jails, which is why, Hugh, I asked you to save your question. Mike?
Okay, so Dr. Hurd and Dr. Keldy, many of us here today know that one of the ways jails are unique is the scope of practice creep. And that due to the intensity and time sensitivity of the booking and intake process, some of the healthcare services are provided by folks that are less licensed or skilled or trained or whatever. What do you see as some of the potential implications of implementing HIT in jails with those considerations?
Yeah, we have with 75 jails in over 20 states, we see a broad range of how things are done in security's house, and we rely on our correctional officers to do a level of triage. They do triage in the field when they're arresting somebody. They do a level of triage, and we have facilities where the correctional officers are very good at asking a number of seminal questions so that they can expedite a referral to a clinical staff member. And we see times when they get a little over their scope of service or make a determination, they'll respond affirmatively to a question they were supposed to refer, and they're busy or they're distracted and they don't. So I think health information technology actually helps you to quantify when that happens and to help prevent it from happening, because when you answer a specific question that you've been hospitalized in the last 48 hours, you don't get to just answer that question and forget about a response to it. That automatically prompts a triaged response from a clinician doing the intake process.
Okay.
Yeah, and I agree, and I think with regards to like a booking process, if you have an electronic medical record in place and you have that ability for a provider to see if it's web-based, you know, a booking officer or a triage nurse or EMT can communicate with a provider who's not at the site. If it's web-based, you can pull up information. And again, if you've got a system that communicates with other systems within the community, it would I think, help this whole idea of this creep as far as the someone doing work that is, you know, kind of outside of their realm. I think it would lessen that. So I think the connectivity piece would be helpful.
Can I delve into that just for a minute and talk about what I think is the elephant under the table? We all know, because of the chaotic environment of jails, we have COs doing screenings that are really assessments that should be done by a registered nurse. We have mid-level practitioners providing care that in a community setting subspecialists would be normally providing. We have correctional officers dispensing medication, which they may not be able to under the scope of practice within their state. That as long as jails have remained an island, nobody's noticed, okay? Nobody's noticed and nobody's cared. I think one of the challenges of health information technology is that it starts shining a light on some of those questions. And if you think about that, particularly going back to Dr. Summers' comments early this morning about health reform and Medicaid, where in order to participate in a health plans panel, I probably have to be board certified. You guys both know what percentage of docs in your facilities are board certified. It's not more than half. Okay. I'm going to have a transparency of some of these functions that are scope of practice creep. I have a general shortage of health personnel in the community. I don't have enough board certified primary care docs to go around in the community, let alone those that want to work in a jail. I don't have enough RNs in the community, let alone those that want to work in the jail. Doesn't health information create an almost insurmountable issue around transparency and building that information bridge in terms of the secrets that we've been keeping about how we manage our business in a chaotic environment?
Can you repeat that question? I actually think health information technology gives us an opportunity. One of our challenges in correctional facilities around the country is a staffing challenge. But guess what? When you have good information technology, good connectivity, good broadband, then what do you have, Homer? You have telemedicine. You're no longer relying on the only person that might come from that community, the only doc in the community. You now can have a face-to-face encounter with a wound care nurse, not just this nurse in the community, with a board-certified physician who can then see patients in 10 different jails in an 8-hour day. So I really think information technology, while it will shine a bright light, and I think that's accurate, the bright light may not be a freight train about to run you down, but it may be the end of the tunnel where we can actually provide consistent care with qualified practitioners who care. So I see it as opening opportunities.
Jar's half full.
Three quarters.
Right?
Yes.
Right.
Yes.
Yeah, no, I think I like the positive spin on it that Dr. Kelly put it, because I do think there's with IT, I think and it was kind of brought up this morning as well, that there's clearly times where IT is going to show us where we've got problems, and it's going to generate probably some headaches for us that are trying to put the right people in jails as far as the staff, because you can't get away with doing some of the things that have been done in the past. And again, the spin with telemedicine, I think it is correct that you do have that ability to, if it's a small facility that doesn't have the ability to bring a doctor in more than a few hours a week, that with telemedicine you can have a provider take care of an inmate from offsite, which if costs are a big part of how counties look at what they can do, that certainly should help.
Okay.
The other spin, with an electronic medical record, you can actually create a clinical dashboard of your highest risk patients, and that was really one of the more successful features of Catalyst. And I couldn't do anything with ubiquitous information. Me knowing every pregnant female in our scope of services didn't allow me to really address who might be at the higher risk. So we found from an intake process a 15-year-old in a juvenile facility, and our OBGYN specialist had a telephone conference, a safety huddle with the site within 24 hours of her coming to the facility. And we do the same thing with oncology, with endocrinology, and this dashboard really helps with risk stratification and identifying patients where we can really make a difference and who really are at risk.
So, Steve, as we enter the world of Medicaid and the exchange, can you talk a little bit about some of the challenges, staffing challenges that we might face?
I think part of it we just talked about, which is this whole issue on participation in health plan. Let me go over a couple of them. I think they're not just staffing. So we all had the pleasure of being hosted by Dr. Venters at Rikers a couple of months ago, and they have a very slow freight train. Between when that young man is arrested and when that young man is actually seen by a practitioner, we're talking in some cases 48 to 72 hours on that assembly line before it goes through. If I have a diabetic young man in the course of that, they're going to be making several ED visits. That's not going to work within a managed care paradigm. I'm going to have to do something about fixing that freight train. I'm going to have to do something about qualified personnel. I love telling this story, and you guys all know it, about a young person who came in who might be rather inebriated at the point of arrest. and a correctional officer does the screen and asks the guy if he's an epileptic or had epilepsy. He goes, oh, no, never. And 16 hours later, he's in general pop and he has a grand mal, and we take him over to the ED, and it's now in my brave new world of health information transparency. And the admitting nurse in the ED gets to see the screen that the correctional officer did, which she decides is an assessment, and next thing you know, she's on the phone with the Board of Nursing. So I think that there are some very significant issues that we're going to have to pay attention to within that paradigm in terms of expectations. And I said, because we have this general labor shortage, I think telemedicine is a great solution. I think in psychiatry, it's been shown to be really effective, and I think most of you guys are using it in psychiatry at this point. I think the question is, how do we manage that at the primary care level? How do we figure that out? And what level of credentialing will health plans make to the folks who are going to be on the other end of that video screen? Yep. So I think there's a whole bunch of challenges, and I think we don't have a lot of time to start figuring them out, quite frankly.
Yeah, 2014 is right upon us.
Right.
So, Dr. Kelly, behavioral health has been removed from meaningful use criteria. And even though we know that funding for behavioral health services in communities is a key to savings in the criminal justice and in our healthcare systems, it's difficult to keep up with the evolving complexities in these HIT and all of its forms and the relationships with the criminal justice system and the social safety net. So the proprietary correctional healthcare industry is trying to lead the way in jails and prisons around coordinated policy, but there is no coordinated policy. So where do you think that leads us as you try to continue in this effort?
Not a simple question. We've siloed mental health care in this country since the 1700s, when they had the first insane asylum in Virginia. And we've siloed them in insane asylums, and now we silo them in jails, and we silo them in prisons. And even in the private world, if you talk about 74% of there being communication between primary care specialists or the primary care clinicians and specialists, the exchange of information between psychiatry and primary care is abysmal. One of our biggest challenges, even in corrections, is to not silo mental health care, is to integrate mental health and medical care. There's a significant trend in the community to doing that, is to taking medical and mental health services and integrating. One of the most promising, I think, steps that are being taken are the patient-centered medical homes. NCQA has certified over 3,000 patient-centered medical homes around the country, and more of the patient-centered medical homes are bringing mental health workers into their office. So you're not making an appointment for them to go see somebody, you're seeing them in their facility. And when we're really doing our job well, that's how we function in a jail or a prison. As a patient-centered medical home, we refer, we know when they've been seen, you get the information back, and I think that's something that we're going to continue to address. It's going to continue to be a challenge, and one of the hardest challenges that we face is what happens when somebody now gets that mental health diagnosis. Now they've been labeled as a psych patient. And once they're a psych patient, that's what I've seen on too many people's their first reflex. Oh, it's a psych patient that's having an asthma attack. That psych patient with diabetes. The psych kind of primes everybody, and the next thing you know, well, I wonder if it's the psych, if it's really a psych complaint. Is it really an asthma attack? Yeah, and we've seen bad outcomes from the labeling of that. So I think that's another barrier that we have to break down. And I'm not sure how information technology is going to assist us with that, Michael.
Good, Dr. Hurd, you got any feedback on that?
Yeah, I don't know that I have anything to add to that.
Okay, all right. So we'll field questions. If anybody has any questions for any of the panelists. We got a question here. Well, hold up for the mic, please.
And please identify yourselves.
Thank you. Steve Spencer, correctional physician. I'm just curious, looking beyond the geographic boundaries of the United States, are there any other countries that are making faster progress or slower progress than the United States in the area of information technology exchange, such as Canada, Western Europe, the UK? And what are the social, political challenges that we may have to face as a free enterprise system that other more controlled societies don't?
Well, I can take a quick stab at that. I think that, any society or country that has a single payer is going to have a system that makes more sense as far as that information exchange. Here in the U.S., as we know, how many payers are there? It's endless, and so the problems until we get to a single payer system, I think, will continue to be very tough compared to some countries that have a single payer.
The flip side of that, of course, is the experiment in the United Kingdom, which does have a single payer, which put billions of dollars into trying to create a top-down EMR system that totally flopped. And so it's a very interesting question that you're asking, Steve.
And, boy, this is the fun part of being here. I can call somebody out. Dr. may be able to actually,
John's there.
actually opine on this, because he's been very instrumental in International Prison Association. We were at a joint meeting a couple of years ago and got to see, if you want to talk about disparities in care in some of the underdeveloped countries versus one of the most incredible healthcare systems and reentry programs that took place in Singapore. John?
Well, thank you. Singapore actually has a very elaborate electronic health record, which does connect to their national health system. So that would be a good example to shine. But there's a variety all across the world, and I don't know that anyone has the market on the right way to approach it. Interesting, Panama has a very elaborate telemedicine program. All of their prisons are connected through their Ministry of Health, and the Ministry of Health is the provider of care. And Mexico is also moving that way through their federal prison system. So those are some examples. But I don't know that anyone in the world that I'm aware of has the right answer. Everyone's moving in this direction, though.
Can I ask a quick follow-up? You mentioned Mexico's federal prison system. What's going on in the U.S. federal prison system?
The Federal Bureau of Prisons actually have all of their federal penitentiaries are actually connected with a single web-based electronic medical record, and that's been deployed, I think, 8 years, Brian?
Yeah.
7 or 8 years in the Federal Bureau of Prison, and 6 years.
6.
Yep.
Century. Okay, any other questions? Okay, no questions.
No, you got questions.
All right, here we go.
2 more.
You got 2 more.
Couple more.
Hi, I'm Kamala Malik-Kane with the Urban Institute, and I had a question that it sounds like one of the benefits of EHRs that you're talking about a lot is that there are, various, I guess, algorithms that are embedded within it to kind of bring things to providers' attention. And I was wondering about the flip side, and a couple of things, I guess, sort of provider acceptance of kind of being guided in certain directions to evaluate certain things and to take certain things into consideration. And if there are places or examples where the guidance of the electronic system in terms of what to ask and what to screen for has failed.
Adoption of electronic medical records are a challenge that are not going to go away. And we've seen both ends of the spectrum. One of our dashboard characteristics that we have is we want to know if you have asthma, have you ever been intubated? Have you ever been put on a respirator? That's a risk stratification. That's someone that's high risk. That's someone you don't need to be waiting 30 days to see them in chronic care. And so when we first started our dashboard, we found hundreds of patients with asthma who've been intubated. Well, guess what? We asked the question wrong. Because when you ask somebody, that's right off the streets that may be inebriated. Have you ever been intubated? What does that mean? I'm feeling a little that way right now. So we changed the question. Have you ever been in a hospital where it was required that they put a tube down your throat? So, you know, and I don't know the exact question, but the rate of intubation dropped precipitously. And many of our practitioners, our nurses, just feel so much more comfortable with the triggers and the alerts and the buffers that are built in. Others feel like this is a pain in the that I have to now put a mask on somebody because they admitted to hemoptysis, coughing up blood. That's extremely high risk, and it does require activity that before they could just click a button and go on. So that's a very good question, by the way.
Yeah, and Cam, I want to try and take that from another angle, and we'll talk a little bit about this later on this afternoon, which is that part of what we perceive at Cochs that the health information technology allows is what we would call a routinization of care, that you basically get to create some standards and standards of practices which promote patient safety. I think, again, because typically jails have been unseen and the providers have been unseen, that those kinds of prompts from where we sit are welcome at this point in the evolution of jail healthcare. I think it was another question on the, yeah.
Yeah, it was over here. Devin McGraw, I'm with the Center for Democracy and Technology. This is my first exposure to this issue from the incarcerated population side, but I've done a lot of work with Judy Murphy and others at the Office of the National Coordinator on encouraging the adoption of standardized health IT and health information exchange. And I'm really trying to pay attention to some of the conversation that's gone on today about the extent to which the records in the jail system need to be somewhat unique to respond to the needs of the jail system, and yet the activity that's going on outside of that incarcerated population is all sort of being driven towards the adoption of certain standardized tools like the CCD, use of standardized vocabularies like the lab vocabulary and the e-prescribing vocabulary. I'd love to hear more about, especially since you all are the industry providers that cover a lot of jail healthcare systems, to what extent are you trying to work on having there be some interoperability between the tools that you're creating and using in a prison-based system, a jail-based system, versus being, again, if the desire is to be able to exchange information with the outside, with the world outside of the incarcerated population, to what extent are those efforts being merged together in some ways? I don't think we're doing a very good job of it at all on our end. On the other hand, I'd be very eager to hear how those efforts are going from your end.
Yeah. I think health information exchange is a pretty lofty goal when the health information that we're gathering has such huge variability in it. And if we're going to exchange misinformation, what are we exchanging? And heretofore, I think everybody knows that the background, if not the backbone of electronic medical records, have been E&M codes, so that you can bill, so that you can document something, that you get a first pass reimbursement. And there really hasn't been much clinical decision support. The clinical decision support is an icon, and you go click on the icon and it says, oh yeah, it's time for a mammogram. True clinical decision support is taking disparate data within an electronic medical record, and while the clinician is there, be able to feed him actionable information. Yes, this patient with diabetes is on metformin and his creatinine is now 1.7. Warning, Will Robinson. To be able to really do this at the point of care and have good clinical decision support. So I think the whole industry of electronic medical records is in its infancy. It's really has been to the digitalization of paper stuff. And I think it's going to be a real challenge to put good evidence-based medicine behind clinical decision support, resulting in actionable information where When people look at the Affordable Care Act, they now just call it the Affordable Care Act. It's actually the Patient Protection and Affordable Care Act. The patient protection is where we need to go with electronic medical records so that we can prevent errors of omission and errors of commission in healthcare practices. And this is the community, the emergency rooms, jails, and prisons all over the country.
And then, Carl, before you wade into that, I want to just add to that. And then you have a population in jail of generally young people that have beat up their bodies with drugs and alcohol, who have no primary care, who have co-occurring behavioral health disorders, for which I don't even think we've thought through what are the clinical decision tools that are needed in that environment. I think the other part of your question, Devin, is that it's not just that the environment is chaotic, it's that the patients that you're seeing are not just the unseen provider, they're the unseen patients, okay? These are patients who are getting their care in the ED with a lot of complexity. And I know Dr. Barton used to tell stories about all the pathology that he would find in young men when he worked as a jail doc. I think both of you guys have found weird pathology in young men in working as jail docs. So I think the decision support threshold in a jail environment is much higher than it is in a community environment. And I think, Carl, as you said, we haven't worked it out in a community environment. Ray, what would you say on this?
Yeah, well, to go to your question, you know, it's a key, you know, it's a goal that, you know, we strive for. With right now, we're trying to get a system in place so we can connect amongst ourselves rather than into the community. We know the importance of connecting to the community because it's going to save dollars. It's going to save us from repeating a CAT scan that might have been done, you know, 2 weeks earlier at an ER that we didn't know about. So I think there's certainly cost benefits to having the connection to that health care for that individual outside the jail, and we're still trying to figure out how to do it within the system and that connectivity with the folks in the community. Clearly important, but we've not gotten there yet.
And I think if you go back to the video, part of what Dr. Brenner is trying to do in Camden is rethink the role of the emergency room in terms of high-cost, high-need patients, that from his perspective, and I think now from the folks at the Camden County freeholders, the county administrator, and the county jail, they want the HIE in as quickly as possible, primarily because of the risk that the seriously mentally ill folks who are unmedicated, who progressively decompensate until I can find out what meds they're on. If you haven't been in this jail before and you're arrested on a Friday afternoon, it's going to be Wednesday or Thursday. Before you get meds, you're sitting in a suicide smock, decompensating, smearing feces on the wall for 5 days and posing a risk for every hour that you're let out. I think in that kind of situation, the HIE has very clear present value, but I think you're asking a bigger question than that, in which I think the value prop is still up in the air.
Any other questions?
Yeah, there's one on the right there.
I just would like to follow up on the...
Could you identify yourself?
My name is Cedric Hendricks, and I'm with the Court Services and Offender Supervision Agency, which is the federal agency in D.C. responsible for supervising men and women on parole, probation, and supervised release. We've got about 6,000 D.C. folks that are spread across the country in the federal prison system. So with that said, I wanted to follow up on the inquiry earlier about what the federal prison system is up to in terms of its own information, medical information, documentation, sharing, et cetera. Because I think it was just said that they have a system that's been in place for several years. But the question for us is, what is its accessibility to those in the community who are healthcare providers? And I ask that and offer an example. Unity Healthcare is a major community provider here. And I was in a meeting where they talked about trying to get medical information about a returned citizen that was at their reentry health center seeking care. And this guy did not have his medical records. He had served a long period of incarceration. They had to submit a Freedom of Information Act request to the Bureau of Prisons with the signed release in order to get this guy's medical records. Now, we have since that conversation seen Unity able to work out an arrangement with the Bureau whereby if they then, through a secured email channel, send that release to a particular person at the Mid-Atlantic Regional Office, that person will pull up what they need because they have access to it, and then send it in a encrypted secure email back to the point of contact at Unity. So that's a workaround that has been extremely beneficial to this community. But heaven forbid that poor lady at Mid-Atlantic go on vacation or die. You know, and not to say that the folk there at Mid-Atlantic won't try and figure out how to back that up, but that's a solution that is really not satisfactory, you know, in this community, given the volume of folk that we have locked up in that system. Now, we at the Parole Probation Office are trying to work out our own arrangement for similar reasons, because, you know, we get folks coming back to us for community supervision who've got behavioral health disorders that are severe and persistent, and physical health issues. And so in order for us, as we do our pre-release planning, to include continuity of medical care as part of that process, we need a certain level of information, which is hard to get because, you know, initially what we get are paper summaries that to some degree touch on medical information. And where you see something that ignites your interest, then you've got to call one of the 120 facilities where this person happens to have come from and say, hi, I'm from the Court Services and Offender Supervision Agency in D.C., and I'm calling the case manager, who's probably the one that put together the summary report, who not necessarily is in contact with the medical people in that same institution, and trying to ferret out through this telephone effort information that I need to help me understand what's in the summary document so that we can make sure that there are timely and appropriate steps taken to facilitate continuity of care when a person comes home. And there are some folk coming back who have some real behavioral issues who we need to have more than sometimes a couple of days or even a couple of weeks to deal with, because then, you know, all these other issues we're confronted with, you know, Medicaid, SSI, ain't in neither one of them, and some of the services out here you can't get unless you got somebody to pay for them. You know, we're kind of left caught often flat-footed trying to deal with these extreme situations. So all that to say that it's great that they have a system, but, you know, people, you know, since it's a national prison system, you know, are in need of really having some kind of effective access to it, so that we can get what we need to plan appropriately for people coming back to us. And we get about 2,500 that come back to D.C. a year from the federal prison system.
So what I find really interesting in what you're describing is not only does the workaround that Dr. Keldy was talking about exist within the correctional environment, that workaround exists back when these folks are back out on the street. And I think what that speaks to me is the extent to which, because we've created this unconnected correctional healthcare system, that what we keep having to figure out almost on a onesie-twosie basis is how do we build workarounds that let us provide the care these folks need both when they're in the correctional institution and when they're back in the community. And the nature of it is all workarounds. And so part of what health information technology offers as a promise, and I don't remember who was my skeptic this morning, but I had a skeptic, I think it was Dr. Stern was my skeptic this morning. I think part of what health information technology offers as a promise is the ability to not have to continually rely on those workarounds. Whether that promise will be fulfilled or not is, I think, another question. Any other questions? Yeah.
Yes, ma'am.
Joan, wait for the mic, Joan. We need a mic up here.
Yeah, I was just wondering, I know you're focusing on jails, and I know that coaches do, but because they're so separate and they're very autonomous, have you thought about trying to deal with the prisons first?
I think when we sit, and Carl and Ray, I'll be curious about this, when we sit, prisons are easier to routinize. They're much less chaotic environments. They're much more predictable. But I don't have a booking issue on, you know, 3/4 of the folks coming in stoned out of their mind or don't know who they are because they're a little bit psychotic. So I think prisons are a lower hanging fruit in terms of routinization. I don't know what you guys think.
That's absolutely correct. And, you know, jails are revolving doors. You know, the average length of stay in jail is 14 days or something thereabouts. And the challenges that presents, you know, health care of these individuals is immense. Again, prisons, they're there for a long time. You can get, when they're going to get out. In jails, they can be bonded out and get out within the community within an hour and you don't know it. So that's where certainly the big challenges are, and that's, clearly where the IT piece, it certainly makes the most sense.
There are actually a number of prison systems in the country that are fully integrated with an electronic medical record, Michigan, Indiana, Texas, to name a few, and there's an important role. It's not the same turnover and risk that you have in jails, but you get parole violators right off the street into a prison.
Some jurisdictions.
You get people, there's ubiquitous movement within a 3,000 bed compound, and when you're going to pass meds and someone's moved, you need to know where they are. There's movement between the different prisons. So I think there's a significant role in prisons, and not only for an EHR, but having the ability to coordinate and communicate between the different prisons.
Yeah. And also because they are often state institutions and the health IT coordinators is usually a state employee.
Correct.
It might be easier to connect them, at least initially, show what the impact is. You could look at the high utilizers, and then maybe it would be easier to move to the jail.
And I have one person in the state who's the director of corrections, unlike 3,300
Exactly.
sheriffs and wardens. Yeah, but that's not Cochs' mission. So different story. Any more questions?
Yeah, Carl.
Go ahead.
We got two.
Got two more, and then you're going to have to.
Mark Stern. I want to amplify something that Carl said about the prison issue, and that is, take Washington State for example. There is a tremendous amount, in fact, there's probably more coming and going of parole violators than there are of the stable population. So there are some state systems that have a significant chunk of activity that looks more like a jail than a prison. And so from that standpoint, within the Cochs' mission, we should not forget them.
Great. One more.
Hi, again. I think there's kind of two separate issues here. I hear from everyone, and as someone who works within corrections, but also more broadly just in the health policy world, it's not just the jail and prison systems that are having the frustrations of the electronic health records. I think for those of us who are not IT people, I being one of those, there was this false idea that once people got on an electronic health record, you could automatically share that information among different kinds of providers and organizations, and you can't. I'm hopeful that we will get there, but I'm going to have no role in that. That is, I'm hoping ONC and some of the other, huge pockets of federal dollars that have invested a lot of time into doing that will get us there. But I think the important thing is that if we don't get jails onto an electronic health record, they miss that train entirely. So let the feds work about making them be able to, because yes, there's a huge need for Homer at Rikers, when he gets someone, be able to stick a straw in the data stream of the surrounding hospitals' electronic health records and the community health centers' electronic health records. We're not there yet. I don't know when that will happen, but I do think we'll get there somehow. But I think the important thing is that if we don't participate at all, then even when it gets there, jails are still going to be in their siloed island of disconnected care. Yeah. And that, I think, would be a shame.
Well, Cynthia, that's why we're having this conference. That's the conference message. You got it. Thank you.
Good, I got it.
Michael, lunch.
Okay, one last question.
Go ahead.
Okay, so stay tuned for this afternoon, because what we're going to do is take a look at a system that's being developed in Baltimore with Greg Warren and his crew that is much further along down the road on this issue and can probably address some of the concerns that we've been talking about. What we're going to do now is break for lunch. I know everybody's excited about that, so we're going to break for lunch, and it's right next door to Thunder Grill here. We're going to go in there, and the table should be set for us, so you just pick a seat, and it's upstairs on the second floor over here at Thunder Grill. We should be starting at around 12:15, and we'll be back here at 1:15. Okay? Thanks.